Monteggia fracture dislocation. It is the fracture of upper third of ulna with dislocation of head of radius. So in this radiograph, here we can see the head of the radius dislocation, and there is upper third of ulna fracture. So how it can be remembered is by Monteggia, M for Monteggia fracture and M for medial bone, which is ulnar fracture, along with dislocation of head of the radius. The causes of Monteggia fracture dislocation include fall on an outstretched hand, hyperpronation or hyperextension state, and also by the direct blow on the back of upper forearm. In the figure, we can see the hyperpronation injury leading to fracture like Monteggia fracture. Now, Bader's classification of Monteggia fracture. There are 4 types of the Bader's classification: type 1, type 2, type 3, type 4. In the type 1, there is anterior dislocation of the head of the radius with anterior angulation of the ulnar fracture. It is the commonest type of classification. And in type 2, there is posterior dislocation of the head of the radius and posterior angulation of the proximal ulnar fracture. Likewise, in type 3, there is lateral dislocation of head of the radius and fracture of proximal ulna with lateral angulation. In type 4, there is fracture of the both radius and ulna, and there is anterior dislocation of head of the radius. Clinical features presented are pain, swelling, deformity, severe loss of forearm movement. It can be diagnosed by X-ray, CT scan, but dislocation of head of radius is often missed. So to avoid missing, diagnosis of dislocation of head of radius is done by McLaughlin line. It is a straight line drawn along the center of the shaft of radius, which intersect with the capitulum. So here in the figure we can see that the shaft of the line passing from the shaft of the radius is intersecting the capitulum. So if the McLaughlin line or radiocapitular line does not intersect with the capitulum, then we can suspect it as radial head dislocation. So going through the treatment, it is very unstable injury, frequently redisplacing. In children, closed reduction and plaster is usually satisfactory. If it fails, open reduction of ulnar fracture and closed reduction of head of radius is done. If that also fails, then open reduction of ulnar fracture and head of the radius with repair reconstruction of annular ligament using forearm fascia or fascial lata is done. In adults, open reduction and internal fixation with plate and screws is needed, and if the fracture is greater than 6 weeks, excision of head of radius is done. Here in the radiograph we can see the internal fixation of the ulnar fracture is done. And note, the surgery is done by Bell-Taussig procedure. The complications include unreduced dislocation of head of radius, posterior interosseous nerve palsy, malunion of fracture ulna, non-union of fracture ulna, myositis ossificans, proximal migration of radius, dislocation of interior radioulnar joint, cubitus valgus deformity.